I now have the honor of introducing Malika Sharma for the talk, Making HIV Care Trauma Informed, Universalizing the Particular. During this session, Malika will assist us to explore the importance of trauma-informed care as an essential element of HIV care. Malika is a physician and education lead in the Division of Infectious Diseases at St. Mike's. She's an assistant professor in the Department of Medicine at the University of Toronto, and she has been involved in the care of some of Toronto's most marginalized communities. I had the good fortune of getting to know Malika when she was the medical director at Casey House, where she was also deeply committed to community education, and I'm delighted to welcome her today. As I think I mentioned, she'll be doing the land acknowledgement, and before we begin, I just wanted to thank the AIDS Bureau and the Ministry of Health and Long-Term Care who support many of us as we do our work. Thank you. Over to you, Malika.
Thank you so much for the introduction. I am excited to talk to you today about trauma-informed care in HIV, and I hope you can all see my slides. I want to first make the disclosure that, I'm not a psychiatrist. I'm also not an expert in trauma-informed care. What I am is an infectious disease doctor and an HIV provider who felt that despite having gone through medical school and residency training and then many years of training as part of that, and then even going out into practice, I felt that I did not have the tools to provide trauma-informed care, and I had to kind of go and do a lot of digging and learning on my own. I felt that I needed to change my practice, not only go beyond what I learned in medical training, but actually unlearn some of that. And so some of what I'm going to talk about today is the things that I've learned in that process. So I want to first start with the land acknowledgement. So to acknowledge that the land on which the University of Toronto operates has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. But I always find myself a bit troubled when I'm doing a land acknowledgement because I think I really want to understand what does it actually mean to decolonize a space and how can we actually engage in decolonization in a meaningful way. So going beyond sort of checking the box and saying that we've done this thing, but what does that actually mean to engage with community? What does it mean to actually change our practice, to change our institutions, and to listen and actually act upon, for example, the things in the Truth and Reconciliation Commission. Today, I want to talk a little bit about trauma and the principles of trauma-informed care. I want to explore trauma, HIV, substance use, stigma, all as interconnected processes. And I want to help us all identify ways in which our individual and collective practices can become trauma-informed. So to start, just setting some groundwork around what is trauma. So trauma can both be the event, but it can also be the response to that trauma. And it's essentially an experience that overwhelms an individual's ability to cope. And that can disrupt safety, it can disrupt someone's sense of self, it can disrupt their self-efficacy, their ability to regulate emotions, and to navigate relationships. Related to the concept of safety is that someone who has had a traumatic experience, they've likely had an experience of boundary violation or abuse of power. And that's almost true regardless of the kind of specific trauma that has happened. And often people who've had traumatic experiences, like all of us, have a need for physical and emotional safety. They may be in unsafe relationships, which can be manifest as a variety of, or sort of many types of violence. And they may also live in unsafe conditions. And I encourage us to think about unsafe conditions, not as the things we're usually used to thinking about, like physical or sexual violence. Those are absolutely true, but also to think about things that are unsafe that we've essentially societally created, right? So things like racism, poverty. There are many feelings that are often associated with trauma, and for many people, those can manifest as feelings of terror, of shame, of helplessness, or of powerlessness. And I want you to remember these feelings when we start to bring this idea of trauma-informed care into the healthcare space. It's also important to remember that trauma is experienced differently by different people, depending on their backgrounds, their lived experience, the entirety of themselves that they bring into a particular situation. So for example, someone who's a migrant, who's had an experience of living in a refugee camp, for example, or who's had the experience of being separated from their children, for example, will experience a situation differently than someone who has not had those experiences. Similarly, things like gender, age, disability, indigeneity, culture, all of those things are going to play into how someone experiences trauma. The example of people who are Indigenous is an example that allows us to think about intergenerational trauma, for example, and how traumatic experiences not only affect an individual, but an entire community and an ancestry and a history. This isn't to try to put people into different boxes, and this list is obviously not, it's not complete in terms of all the different things that impact how we experience trauma, but it's just to highlight that idea that those identities come into play. And so why do we, as healthcare practitioners, as people, need to know about trauma? Well, one is that it's highly prevalent, right? So we know that there are many, many types of trauma that many, many people have experienced. And this can be individual or collective trauma. And in particular, a lot of the people that we see in the HIV sector will have experiences of trauma. So there's higher rates of trauma described in people who use substances, people who have mental health concerns, people living with HIV, people who are migrants, etc. And this is just kind of a slide demonstrating that, right? So this is all adults in Canada, not specific to HIV. 32% of adults in Canada report having experienced some form of maltreatment as a child, whether that's exposure to intimate partner violence, which is kind of the big third, neglect, which is another big third, and then the other third made up of physical, emotional, or sexual abuse. It's also important for us to start thinking about trauma as a risk factor. The words risk factor are sometimes troublesome, and certainly, the word vulnerability I really don't like, because it implies that the problem is within the person. But trauma is associated with future adverse outcomes like chronic pain, cardiovascular disease, sexually transmitted infections, substance use. Substance use is not all the same. And so recognizing that this is specifically talking about problem substance use that is not helping the person. Metabolic syndrome, which is a constellation of things like diabetes, high blood pressure, high cholesterol, etc., and then mental health concerns, specifically or especially depression and PTSD. One of the studies that people talk a lot about when we're talking about trauma is the Kaiser ACE study, or the Adverse Childhood Experience study. So I thought I would be remiss to talk about trauma without at least mentioning the study, which was a large study that essentially, it's this large retrospective cohort that relied on self-report to essentially examine the relationship between childhood abuse, neglect, household challenges, and later life health and well-being. One of the things I find a bit tricky about this, though, is that if you look at the demographics of the people that were in this study, do they necessarily represent the people that you're seeing? So, for example, in this study, 75% of people were white. It was an American study, which is the other sort of piece of it. The bulk of people were actually 60 and over. And actually many of them either had some college or were a college graduate or higher. So, does this necessarily reflect the population that you're serving or that you're working with? It may or may not. But what it essentially talks about is this idea that, from conception, so from, cradle to grave, this idea that there are mechanisms by which early experiences influence health and well-being throughout the lifespan. So things like, generational trauma, like we were talking about. So for example, the 60s scoop or residential schools for Indigenous peoples in Canada, social conditions or local context. So that would be, what are child poverty rates in Canada or in Toronto. And then specifically adverse childhood experiences, so some of the things like we were talking about, neglect or specific trauma, and then how that might lead to disrupted neurodevelopment, social, emotional, and cognitive impairments, adoption of health risk behavior, again, some problematic terms, but this is what the study talked about, disease, disability, and social problems, and early death. So this is, again, what the study talked about, and they talked about these various traumatic experiences in sort of three main buckets or categories. So they talked about various types of abuse, various types of neglect, and then various household challenges that people may have experienced. So having someone incarcerated, undergoing a separation or divorce, mental illness, substance use, or violence towards their mother. And again, these are the categories that they used. And what they basically found, I don't want to go into this in too much detail, but they basically found, high rates of prevalence of various types of abuse, including, substance use and sexual abuse being sort of the two most common. And in a nutshell, what they found was that there was a strong dose-response relationship. So the more things like from these categories that people had been exposed to during childhood, they had a graded relationship to essentially future conditions of ill health. And so they essentially summarize this as the impact of adverse childhood experiences on adult health status is strong and cumulative. And those effects can be manifest as injuries. So they found increased rates of traumatic brain injury, fractures, burns, mental health conditions like we've talked about, maternal health outcomes, so either unintended pregnancy, pregnancy complications, or fetal death, infectious disease, including HIV and sexually transmitted infections, chronic diseases like cancer and diabetes. Again, what they term as risky behaviors, I find those terms problematic, but problematic alcohol and drug abuse, or again, problematic term, unsafe sex, but this is again how the study has talked about it. And then limitations and opportunities with regards to ultimate income, occupation, or education. So that's all sort of the childhood stuff. But part of the challenge is that engagement in healthcare, regardless of actually whether there's been previous trauma or not, can be re-traumatizing. Certainly for people who've had, it can be traumatizing in the first place, or it can be re-traumatizing. And some of that is related to system things, so policies, procedures, and kind of the way things are done, or relationship stuff, so interpersonal things related to power, control. So for example, one of the systems problems, and this is particularly true when I think about myself in a teaching hospital, is patients often or clients have to often continually retell their story. They may describe being treated as a number. There are often procedures that require disrobing, which may be necessary to do the appropriate examination, but is it explained? Is it understood why that's happening? Is it done in a safe way? People often describe being seen as their label. So instead of being, a 37-year-old gentleman who has this rich and full life who also has schizophrenia, they're a schizophrenic. People also describe feeling like they have no choice in their service or their treatment that they're receiving, and in particular feeling like they have no chance to give feedback or to improve future interactions because they can't give any feedback about this experience that they had. In terms of the relationship piece, people often talk about feeling like they're not being seen or they're heard, their trust being violated. One of the biggest examples that I've heard people tell me again and again is, for example, going to get their blood work done and having some element of their medical history said out loud in front of everybody in the waiting room. Things like failing to ensure their emotional safety, which may go back to things like the disrobing piece, etc., but it's at the individual level that we're talking about here. People often talk about this idea that their care was not collaborative, so they were told what to do rather than what do you want done? What are your priorities today? And then feeling like people were doing things for them rather than with them. And then particularly I see this happening with people who use substances, although it happens to in many types of scenarios with many people, is the use of punitive treatment or coercive practices or oppressive language. So, well, you'll only be able to get X if you do Y, right? So that's a very coercive way of practicing. And I particularly see that around substance use. So these are all the ways in which it's re-traumatizing sometimes to engage in healthcare again. But do we need to know about trauma to be able to take action against that? It's important to remember that disclosing trauma itself can be re-traumatizing. It may also lead people to disengage with the care that's being provided or with the clinical encounter because, now they've revisited that trauma and they may feel this need to kind of close back in on themselves. And so if there is a space or a desire for trauma to be disclosed, maybe it's important for the patient to want to be able to disclose their trauma and have somewhere to talk about it. The space and safety needs to be created around that, and we'll talk more about that in a bit. I think it's important to mention just briefly around trauma and substance use, which I've talked about substance use a few times. Substance use can actually feel like a very reasonable response to trauma, right? It's an adaptation to cope and to survive and to get through the day. And I think many healthcare providers don't necessarily make that connection or sort of see it in that way. It's not something that someone is doing to make things more difficult or certainly, like, as a healthcare provider, like, it's a very egotistical approach to feel this sense of it's making things more difficult for me. Like, it's not about us, right? And so really this substance use and trauma can be closely related because the substance use may be a way that people are mitigating their traumatic experiences. With regards to HIV specifically, there's been a few different studies that have looked at trauma and HIV. And so one study found that 30% of infected individuals in that study had experienced childhood physical and or sexual abuse before age 13. In one study, up to 95% of HIV-infected women had experienced intimate partner violence, which is an astounding number. Up to 77% of men, still an astounding number. And again, 93% of transgender people. Like, these are, I'm going to talk about that idea of universalizing the particular, but this really speaks to that, right? Everybody's experience is individual, it's specific, it's particular, it's unique to them, and it warrants, specific care for that person. But there is a universality to this, which means that we need to really be approaching healthcare spaces, and particularly HIV spaces, but really healthcare in general, from a trauma-informed place, with the assumption that we're all experiencing trauma. And even if we're not, we should probably be acting in ways that don't further traumatize people. What we know about trauma and HIV is that it is associated in people living with HIV with poor mental health outcomes, substance abuse, again, problematic terms, but this idea of higher risk sexual activities, lower participation in HIV care and treatment, more frequent opportunistic infections, and a higher risk of death. I think HIV and TB care is another interesting and important area that we should talk about specifically. Many people living with HIV have higher rates of TB, and particularly if they're coming from places where TB is more endemic. So there's a racialized component to this. And there are specific issues around trauma. So one of them is surveillance, right? So a lot of the letters that go out about TB surveillance, they talk about surveillance, and surveillance itself has very traumatic implications, especially if people are coming from countries where they've experienced political violence. There may be stigma associated with the letter that's coming. TB carries its own infectious stigma that is separate and unique, but interrelated to HIV. There may be the same feeling of surveillance associated with directly observed therapy, especially when it's not explained why directly observed therapy is happening, right? Do we talk to patients about how the evidence is so much better for directly observed therapy versus not? Or do we just say, we're going to watch you take your pills, which implies we don't trust you to take them, right? There are issues of knowledge asymmetry. There's the issue of, is this mandatory versus optional? As you know, active tuberculosis is treated with a public health lens in mind. And so there's this idea that, treatment is essential for the greater public health, but how can we engage with people to see that as a collective action as opposed to you have to do this? There may be a focus on their infectious/contagious issues. And I used air quotes to say contagious, which you can't see me doing, because it is contagious, but the focus is on that. And there's a neglect of other issues such as mental health concerns. There may be a lack of comprehensive care. There may be many, many providers, and so it gets confusing for people, and there may be costs associated that we often don't think about, right? So things like travel, etc. And so then, do we need to know how to treat trauma? I really liked this quote because it helped me feel much more comfortable taking a trauma-informed care approach without having all the answers. So there's real advocacy for trauma-informed approaches in the substance use treatment field, but I think you can insert, HIV or other healthcare concerns in that same slot. Do not ask substance use treatment professionals to treat trauma, but rather to approach their work with the understanding of how common trauma is and how it is manifested in people's lives, right? So you don't need to know all of the ins and outs of how to treat trauma. And that leads us to understanding the principles of trauma-informed care. So what makes a service trauma-informed? So one is it factors an understanding of trauma into all aspects of service delivery. And I'll talk about what that looks like. And it prioritizes physical and emotional safety, choice, and control in decision-making. Some elements of trauma-informed care, so going back to this idea that it's essentially in all aspects of service delivery, it's not just about me as the doctor or as the social worker or as the nurse or whoever is involved in the one-on-one care, it's everything. It's the signage, it's the physical space, the intake procedures. Is it explained to people why questions are being asked or why tests are being recommended? Do they have clear information on what services and programming are being offered by this organization or by this institution? Are they involved in shared decision-making? Is there clear, informed consent and expectations around confidentiality? So these are kind of some of the key elements, and we're going to talk a lot more about this in detail. Trauma-informed care is related to some other concepts that you may have heard about. So things like cultural safety, which is a concept that has been developed particularly from the Maori peoples around this idea that really, one, only the client or the recipient of the care is the one who can say whether that care has been has been culturally safe or not. It is different from ideas like cultural competence and this idea that we can somehow become competent in understanding someone else in that way, but really this idea that this is a dialogic, safe space that's created for people in which their entire selves are being brought to bear. And it's also related to harm reduction practices, which many of you are probably familiar with. So they're not the same, but there's a clear overlap between these concepts. Specifically with harm reduction, we think about ideas of safety and engagement, which are fundamental to both principles. This also relates to some ideas around cultural safety, but some of the principles in trauma-informed care are the idea of nonviolence, of learning together, and the idea of collaboration. And so to kind of summarize that a little bit, so key principles is, one, there has to be trauma-informed awareness. There has to be emphasis placed on safety and trustworthiness. And these two things together need to allow the opportunity for choice in care, collaboration around that care, and for true, authentic connection. And part of this really only happens if we focus on people's strengths and resilience and on skill building, as opposed to like a deficit-based approach, where we see people as coming from a place of these are the things that have gone wrong, as opposed to these are the things that people are doing for themselves. So that awareness piece can be broken into, what is the prevalence in your key population that you're serving or that your organization is serving? Is there substance use that may reflect trauma or that may be related to trauma that has been explored? Are there mental health concerns? And when there are mental health concerns, is trauma being considered as part of the care plan? In terms of safety and trustworthiness, again, this goes back to those ideas of the intake procedures. So, not just having the pride flag up, but then actually having appropriate ways to enter your gender on intake forms, for example, or having a way to specify what name you go by. Is the physical space such that people can guarantee confidentiality even when they're being approached in the waiting room, for example? Are there toys for people's children to play with, which recognizes, an acknowledgement of them as a whole person, which includes parenthood? Is it explained when questions are being asked or diagnostics or recommendations? As an HIV provider or, as a sexual health provider, I sometimes ask very, very detailed questions about people's sexual practices. And if I'm not explaining why I'm doing that, certainly for people who've had a traumatic experience before, but also just in general, people can feel like, well, why is she asking this? Is it for her own interest, for her own voyeurism? So it's important to specify why we're doing the things we're doing. And then these are some of the other concepts that we talked about already. I think it's also important to remember that trauma-informed care can refer to practitioners as well. So many of us can experience vicarious trauma, which I'm going to talk about a little bit. And vicarious trauma is related to the concept of burnout, which many of us, I think, have become familiar with, especially as it's making more kind of media headlines in the era of Zoom, which ironically we're all on right now. There can also be interpersonal violence that takes place, and then structural violence. And part of this may be a recognition that your institution is enacting racist practices or an erasure of Indigenous peoples because they're not allowed to smudge in the building because of, rules that have been put in place for cigarette smoking. And so it's important for us to think about how we ourselves are not just implicated, but affected by some of the institutional practices that we live in. Vicarious trauma can also be related to this idea of compassion fatigue. And I really liked this definition that I read at the websites at the bottom, but it's this emotional residue of exposure that counselors, but really other healthcare providers as well, have from working with people as they are hearing their trauma stories, becoming witnesses to the pain, fear, and terror that trauma survivors have endured. It can be really hard to take that home. And there can be various signs and symptoms of vicarious trauma. Like difficulty talking about your feelings, sorry for the typo, the free-floating anger or irritation, having a startle effect or being jumpy, overeating or undereating, difficulty falling asleep, staying asleep, losing sleep over patients. This can also be related to dreaming about your clients, their trauma experiences, being constantly worried that you're not doing enough, feeling trapped by your work, not enjoying things you once enjoyed, having less feelings of satisfaction or personal accomplishment. Intrusive thoughts can be manifest that way, or just feeling hopeless about kind of the work that you're doing, and then blaming others is also a sign of vicarious trauma. So that all is sort of the background piece. It's always hard to kind of have a bit of a interactive component for Zoom, I guess. But just at this point, I'm wondering if, please feel free to put in the chat, for example, or just to let me know in any way if you feel like this has kind of been an okay pace and a good enough background for where we're at. And maybe you can let me know in the chat, because I'm going to move on to talking a little bit more about what trauma-informed care can look like in practice. So this slide, and this is a good chance for people to put things in the chats because I'm going to spend a couple of minutes on this slide. This kind of emphasizes some of the stuff we've already talked about. So some of the key components of trauma-informed care. So one is incorporating the approach in every aspect of the organization, so truly creating cultural change, and demonstrating greater awareness of the impact of trauma on all people that are served by the program, the organization, or the system. That includes its own workforce. So this goes back to the idea that it has to be reflected towards us as well. And, it has to involve an acceptance of that, trauma influences the effectiveness of all services that we provide. And so how do we create a solution-based service approach that recognizes the pervasiveness of trauma, that changes the thinking from what is wrong with this person to what happened to this person? How do we make sure that staff at all levels change their behaviors, their actions, and their policies in keeping with this kind of approach? And how do we essentially remain vigilant in anticipating and then avoiding institutional practices and policies, as well as individual practices that are likely to re-traumatize individuals who already have a trauma history and to traumatize individuals who don't? So I talked about this a little bit, this idea of there's a deficit perspective to a trauma-informed and strengths-based perspective. And that one of the first things we can do is think about changing our language and to think about that. So that idea of from what is wrong to sort of what has happened, thinking about symptoms and thinking about adaptations, right? So, many ways in which people manifest are adaptations to the traumatic experiences that they've had. And that actually makes a lot of sense, right? We often talk about disorders, right? So substance use disorder, but thinking about things like response and how this is a response. And this is, again, not to assume that everybody who uses substances has had a traumatic experience, but part of it is essentially practicing as if they might have, so that you don't have to know about the trauma to have a trauma-informed approach and to act in a way that is strengths-based and caring. Some terms that people may have heard is things like attention-seeking or borderline or controlling. These are, I think I probably don't have to tell this group that these are, pejorative. This implies that I'm the one having the problem here, right? As the provider, this is irritating to me for some reason. But how does the way that I think about this person change? Let's say someone's yelling at me because, they're not liking an element of care or the wait time that they've had in the waiting room. Rather than me thinking about these things, how would it change when I start to think to myself that, this person is trying to connect in the best way they know how, or they're doing the best that they can given their early experiences. And this is not it's important for us to remember, this is not to condescend to people, right? But it's trying to come at it with a place of compassion and humanity and sort of being like, given the experiences they've had in other healthcare spaces or in other experiences, have I created the safest space for them? And is their current response actually quite understandable? They may be trying to assert their power, which maybe reflects the fact that they feel powerless in this scenario. So how can I fix that as opposed to the fact that I'm unhappy with how they're behaving, for example? Similarly, we may feel people that are, we may feel, or language we may have heard is, oh, people are manipulative or malingering. But really, it might help us think about it in the way that, maybe this person has difficulty asking directly for what they want. Or maybe they're seeking help in a way that feels safer to them than having to ask for it directly. And thank you for the feedback. I will try to slow down a little bit. Going back to that TB HIV care example, so how could things be made trauma informed there? So, intake procedures might recognize that people may have experienced traumatic experiences or political violence, and we may think about the language we use. So maybe instead of saying things like surveillance, recognizing that it has specific implications for people, we might use other words that are more neutral in that sense. Ensuring that care is always language concordant, that it's not a hassle to get the translator, that's an expectation of appropriate care. Balancing the need for standardized care with tailored expectations. So, recognizing the complexity of people's lives, their work schedules, their childcare availability, and making sure the care we offer is cognizant of that. That relates to this idea of having a holistic approach to care. So not just focusing on the TB or just on the HIV, but actually being able to address some of the other issues that might be going on for people as well. And the idea that decision-making is shared, so that we really are sharing the information so that people can come to their own decisions and choices from a place that feels empowered and like they have autonomy. And this idea of universal precautions. So I think it's worth taking a second to talk about the idea of universal precautions. Universal precautions, usually when we hear that term, particularly as an infectious disease doctor, but often it refers to the practice of wearing gloves or washing your hands, wearing gloves, plus or minus a gown when you're doing certain things, like, for example, changing a Foley catheter bag, or, where you might be touching urine, or doing a procedure where you might have the possibility for blood, like inserting an IV line, for example. So it used to be that universal precautions were not involved, and so they would really only be used when there was a concern, a specific concern around contagion, essentially. And so you can imagine that in the early days of HIV, this was really loaded and really filled with stigma, right? So only certain people got gowns and gloves and masks and all of that. And that really, you can imagine how that made people feel. And also what it creates in the provider, right? When you're doing that for certain people and not for others. And part of that recognition of stigma and essentially re-trauma, but also a recognition that probably we should be doing this for everybody, because then we're always safe and we're also being safe for the patient, right? So we're protecting both of ourselves. And that shift in thinking about that this is universal, I think has gone a long way to, people expect that you should wash your hands before you come into the room. They're not just washing them because of you, right? They expect that you should wash your hands after you leave the room. It's not just because of you. And I think similarly, a trauma-informed universal approach takes a lot of that stigma assumption out of it, because you're not assuming that this specific person's had trauma because of the way they're appearing or the way they're dressing or their substance use or any of that. You're assuming it because we know trauma is very prevalent, and that assumption allows us to have more compassionate care for people. And again, it's not an assumption that this specific person has experienced trauma, but really more that we all potentially have experienced trauma. I think within specifically around this kind of universal precautions and HIV piece in particular, I think trauma-informed approaches can help us recognize stigma as a potential trauma. I think about, a patient that I worked with quite closely who described an experience of someone throwing in an umbrella to pull out the garbage can from their room to change the garbage bag because they didn't want to enter the room of a person living with HIV. And that was a traumatic experience for them. It helps us be mindful of how is stigma playing into this interaction. And if we're mindful of it, then we can actually address it. I think people are often uncomfortable talking about the idea of stigma. It's like, racism. If we don't talk about it, it's not there. But that, for people who are experiencing it, we know that that's not true, right? So I think it's actually really important to have some of these conversations and then to also act in a non-stigmatizing way. And I think having a trauma-informed approach, it's almost like a slowing down, right? It can help us just sort of take stock about how we're behaving and how we're showing up. So just a reminder of what we've talked about already, and I know that I've gone a bit fast over some of these things. Partly it's because I know I come to them again and again and again. So just to kind of reiterate, trauma-informed care involves this idea of safety, physical and emotional safety. An example of that in practice is common areas are welcoming, where privacy is respected. The idea of choice, right? So people have choice and control. And in principle, that might mean that people are provided with clear and appropriate messaging about their rights and their responsibilities in that healthcare environment. Collaboration means sharing power and decision making. And so in practice, that might mean that the client has a significant role in planning services and evaluating services and letting us know whether it worked for them. Trustworthiness is essential. So having clear expectations around what the tasks are, having consistency, demonstrating clear interpersonal boundaries, right? And that's, respectful and professional boundaries does not mean that we act like robots or that we don't engage in laughter and compassion and, that we're not there for people when they're crying. I think often the way we're taught about professionalism is in a way that's kind of robotic and not human. That's not really what we're saying, right? So in practice, professional boundaries being maintained means that we can do all of those things for people, but with clear expectations around, how that compassion is being manifest, where it's being manifest, and where those boundaries live. Empowerment is sort of another key principle of trauma-informed care, the idea of prioritizing empowerment and skill building. And really, that means in practice, an atmosphere where people feel validated and affirmed with every contact. And the idea that we're, not approaching them as someone who has all these flaws or deficits or things that are wrong with them, but really someone who's working towards building their skills or who's taking a proactive approach in their own healthcare just by being there, for example. So this is where I sort of make myself a little bit vulnerable and talk a little bit about what does this look like in practice for me. I had another patient who was born here who started using crystal meth, and another patient who similarly started using meth and GHB kind of in a chemsex context. And for both of those patients, it was, substance use had not been something that we had talked about really for the first 3 years of our clinical relationship because it wasn't really a part of what was going on for the patient. We'd ask about it and it wasn't really there. But really, what came out as they started using substances was how much trauma was actually a part of what was prompting that substance use. And a lot of our conversations actually ended up being about some of the experiences that were brought up for them in the context of substance use, or why they were using substances and what it allowed them to do, and particularly around some of the homophobia that they'd experienced and that they were continuing to experience. And so it really created opportunities for those conversations. And it sometimes meant that I had to put the HIV piece on pause, right? Like, we're not going to spend our time today talking about CD4 counts and viral loads because that's actually not what the patient or the client needs right now. One other thing I'll say about that is, for me, like, I am not a gay man in Toronto. And so, I know a lot about, I shouldn't say a lot, I know some, right, about crystal meth or the chemsex scene or all of this through my patients, essentially, who are teaching me and through my own attempts to learn. But it's not my experience. And so sometimes I use the wrong language, or sometimes I don't know something that they're referring to. And so for me, part of trauma-informed care is also the act of humility and telling people, actually, I don't know much about that. Can you tell me more about that? And creating the space for an open and honest conversation. I wanted to share a brief example of trauma-informed care and stigma. And this was something that I wrote about a client that I worked with who, it was a really neat experience, actually. So he and I, after having talked about all the medical stuff, would often talk about books. And when we were talking about books, sort of talking about this third party thing, right? Like, we're not talking about his physical symptoms. We're not talking about a traumatic experience that he's experienced in hospital lately. Like, we're talking just about books. Those conversations often opened up spaces of like a shared humanity, and so much about this patient's childhood trauma came out in those conversations about books. And it actually led me to write this kind of reflection, which really interestingly, I'd given to him to read. And that in and of itself was a really neat conversation about kind of what we were both taking out of those clinical encounters. And so I guess kind of the point of talking about this example is that, trauma-informed care, for me at least, has allowed for a much more human practice. So kind of to end with, some of the things that I ask myself with regards to trauma-informed care about my own practices are, again, kind of thinking about it in terms of buckets, like structural stuff, interpersonal stuff, and personal stuff. So structurally, do my intake procedures meet their needs? And the answer is not always yes, right? So I'm not saying that I'm doing all of this well. It's just that these are the things that I'm asking myself and trying to improve. So, are they being treated kindly? Are they being dead named? Are they being, forced to identify private information in the waiting room? Do my hours meet their needs? When I had my HIV clinic at Maple Leaf, I was only there 1/2 day a week, which was a function of the other places that I worked. But, that's not the most accessible for many people. And so are there ways that I can change that? And if not, then are there ways that I can be upfront about that, or also recognize that then maybe it's best for them to be somewhere that is able to accommodate those things? And how can I make sure that I facilitate that kind of care for them? Are there signs or policies that act as deterrents? So even if I'm not going to apply it to this patient, do they feel the stress of, am I going to be billed for something? Or is there like a 3 strikes you're out policy, which, many clinics, for example, do? So making sure that not only are those policies not in place for me, but, can I advocate for them to not be part of an institution? Are there interpersonal things that I can work on? So are expectations clear and well outlined? Expectations for myself and expectations for them. Do I have a clear plan in place for them? Have we worked on that plan together? I really like this idea of, are we avoiding confrontation but comfortable with conflict? Right? So we're not always going to agree about what the best plan is, right? So maybe I think now is the right time to start treatment and they're not ready to do that right now. So that's a conflict, but it doesn't have to be a confrontation. We can approach that with, humility. We can approach it with kindness, and we can approach it from a place of shared decision-making. And am I taking a strengths-based approach when I think about my patients and when I talk to my patients or clients? From a personal perspective, am I comfortable ceding control, right? Particularly as a physician, our medical institutions are very hierarchical. Physicians are often placed at the top of the hierarchy, which I find very problematic. So not only am I comfortable ceding control, but even that word ceding, like, why is that control mine in the first place? Am I comfortable troubling those hierarchies and trying to dismantle them? Do I know how I'm showing up in this space? So, recognizing that we also have our own stuff going on, right? I've got a lot of anxiety today around our school is going to close again. I have 2 young children. So how am I showing up in this space? And if there are reasons why I can't show up fully, or maybe a better way to say that is, if there's a reason why the way I'm showing up is a reflection of my full, complete self, which includes those anxieties, is there a way for me to not necessarily talk about myself or bring that into the space, but for me to kind of acknowledge that and work with it? Do I know where my resources are? So this is a big one, right? So we often think of ourselves as kind of these lone rangers, and we're not, right? We work as part of community, we work as part of organizations, and knowing where your resources are is also part of trauma-informed care so that you can provide the best care for the person you're working with. And it sounds very basic, but I kind of try to always ask myself, like, am I being kind? And so again, some of the structural things, reviewing your signage, ensuring the hours and access meet the needs of your clients, assuming trauma, building, which doesn't mean, assuming specifics about that patient, but assuming that there is trauma so that you're building trauma into every process. Consent for touch, consent for ordering tests and treatment, making sure you're training frontline staff, and creating a structure for debriefing for yourself and with your clients. And then some of the interpersonal things, right? So explain why you're doing something or why you're asking something. Ask permission. I really like these ideas of, is there anything I can do to make your visit and exam easier? If I just ask that for everybody, they may or may not disclose trauma for me, but, they may also open up the opportunity for them to say, actually, it would really help me if you did X. People sometimes ask, is there anything that makes seeing a practitioner or having a physical examination difficult for you that I should know about or that I can factor into this interaction? Offering control. And, it's not so much offering because it's yours, but this idea that the control is there to be shared and that the decision-making is there to be shared, and finding supports to help you do this work. And then some of the personal things. So recognize your own limitations, recognize your strengths, be kind to people, try to look at yourself from the outside. So how is someone else perceiving me right now? What are things that I should work on? And I think a key thing is separate intent from impact. Your intent is great, but it actually is far less important than the impact that you're having, right? So if I do something that has caused someone to feel neglected or hurt or pressured, my intention is kind of irrelevant, right? It can make me feel better, but ultimately the impact was there, and that's the thing that I need to atone for or fix or change. And so ultimately, to me, this is akin to employing a universal precautions approach. Sometimes in infection prevention and control language, this is called routine practice, like the idea of washing your hands and wearing gloves for certain procedures is routine practice. To me, this is the idea of routine practice for interpersonal care. Like, how do we care for people from a universal precautions approach?